So our project was also for the Americans for Cures Foundation and also on the topic of Proposition 71 with a slightly different twist. So for the past 10 weeks, we've been analyzing the potential cost savings resulting from stem cell therapies that are funded by Proposition 71. And just to give a little bit more background, as the previous group mentioned, the general obligation bonds gave $3 billion in funding to stem cell research, and while only 10 successful trials have effectively moved forward, it did provide funding for over 29 different therapies. And these stem cell therapies are quite revolutionary. They address a partial to full cure, hopefully, for many different afflictments, from cancer all the way to paralysis. My name is Stacey, and I have my team members Jeremy, Jin, and Christina, as well as our advisor Larry, here with us today. And in today's presentation, we're first going to go over the scope of our project, as well as our methodology, and then we're going to go into disease-specific analysis of the cost savings resulting from type 1 diabetes, breast cancer, and HIV AIDS. And we're going to do a background, show you the different cost saving scenarios, and then an analysis of each section. And then we'll finally move into the next section of our report, which looks at the pricing of these drugs, backs out net potential cost savings, and then savings to the state of California. So first, outlining our project scope, we elected to analyze the cost savings resulting from 3 specific therapies, and we elected to project these cost savings over a 10-year time period after these drugs come to market. That's for 2 main reasons. First of all, it's before the patents on these therapies expire. We felt that after the expiration of the patent, the price would change so significantly that it could invalidate our results. Secondly, we felt that medical technologies could also progress significantly by then, so that our cost savings numbers might also be off. So that's why we chose the 10-year time horizon. The next thing that we did was focus on direct medical costs, as well as lost income due to work productivity, but we exclude the analysis of reduced side effects from current drugs, which could potentially be large. We felt that it was really difficult to quantify these effects because they're so specific to each individual patient. We made several assumptions as we went through our analysis. The first one was that all therapies would come to the market within 5 years. The next one was that all therapies would ultimately be successful through phase 3 of clinical trials, the last phase, and would also gain FDA approval to come to market. And the final one was that interest rates, as well as inflation rates, would remain constant over the 10 years. In terms of selecting diseases, we selected our 3 conditions based on the following criteria. We wanted to study things that had high prevalence, also existing literature, and finally had a very specific therapeutic mechanism. So based on this, we elected to analyze type 1 diabetes, breast cancer, and HIV AIDS. And as we measured the cost savings attributed to these specific diseases, we endorsed the following methodological structure. So first of all, we looked at the direct medical costs that are associated with each disease. And these are the costs of inpatient and outpatient procedures, as well as medication costs, tests for these diseases, but also their secondary complications. The next thing that we looked at was lost income due to work productivity. So this is due to presenteeism, or when you're at work and you have reduced productivity, due to absenteeism when you have to miss work, and finally lost income due to early mortality. We then varied these based on different outcomes of therapeutic efficacy, whether it was a partial cure or a full cure, and then we multiplied it by the California patient population, which we backed out using prevalence numbers, or the percentage of the population that has this condition, to get annual potential cost savings. Now, the second part of our analysis projected the price of each therapy and subtracted it from that annual potential cost savings to get net cost savings. We then projected this over 10 years, accounting for inflation, growth rates in the prevalence, as well as population growth. And our disease-specific sections, which are now going to follow, cover the first step of this analysis, which Jeremy is now going to dive into for type 1 diabetes.
All right, thank you, Stacey. Okay, so the first disease that we analyzed in our report was type 1 diabetes. Just a little bit of a biological background. Type 1 diabetes is the chronic autoimmune disorder which destroys the islet cells found in your pancreas. That's significant because the islet cells are actually used to produce the regulatory hormones that help regulate the blood glucose in your body. This is significantly different from type 2 diabetes because basically the body develops a resistance to insulin. And so you'll see that the mechanism of the actual stem cell therapy we'll be analyzing really only aids in type 1 diabetes as opposed to type 2. So some quick facts and figures. First of all, the prevalence in California is about 0.526%, and that translates to about 201,534 patients in California. And the current treatment is daily insulin therapy through the use of daily or multiple injections. as well as the use of a pump that's usually put at your waist. We've also counted the fact that with having type 1 diabetes, you can actually attain secondary complications because with having irregular blood glucose levels for a prolonged period of time, you can develop cardiovascular disease, nephrological complications, as well as other ophthalmic conditions. So the stem cell therapy is, on this past August 19th actually, the FDA approved ViaCyte to conduct a phase 1 or 2A trial, which is the safety and efficacy stage. The two main things you have to know about this trial is, one, they implant what they call the Encapture device, which you'll see on the right. And this is basically a small packet that is encapsulated full of pancreatic progenitor cells, which develop into the islet cells that type 1 diabetes actually destroys. Surrounding the packet is this semi-permeable membrane that allows the necessary proteins and nutrients to go in, and the necessary outputs like insulin and glucagon, the hormones that regulate your blood glucose, to go out. So that's the first step, and then after that, they monitor your C-peptide formation. What this is C-peptide is a protein that results from producing insulin, and so that's just kind of highlighting how they're able to really monitor whether this trial is safe and whether it's effective. Now, some of the therapeutic benefits, essentially, if this packet works, you're basically implanting what's a fully functional artificial pancreas into type 1 diabetes patients, because it's able to regulate the blood glucose, and also it's able to block the autoimmune response. And as you can see in the illustration, the immune cells are hitting the semi-permeable membrane, but ViaCyte has made the technology where it can actually negate the effect of the immune cells. So we start with the assumption that these therapies will undergo success, but we should also, we conservatively assume that what degrees of success are we going to be seeing. So we interviewed Dr. Peter Stock from UCSF. He's one of the co-principal investigators of the ViaCyte trial. And the main takeaway from that interview is that there are two significant hurdles to attaining clinical or therapeutic benefit from this therapy. And we highlight that these are two significant hurdles. He actually quote-unquote said that it would be the holy grail of a type 1 diabetes cure. And that's the two significant hurdles are, one, attaining insulin independence, and two, having a low immune response. It's tough because this trial has just begun. There are a vast array of potential possibilities that could happen at this trial, but to simplify matters, we've said that there are two possibilities. We can either attain full proportion of the population attaining insulin independence and a partial proportion of the population attaining insulin independence. We said that was 44%. This was this was advised by Dr. Peter Stock, saying that we look at current islet cell transplant therapies. Islet cell transplant therapies are basically taken from a deceased donor. And what they've found is currently the state-of-the-art, only 44% of people undergoing that treatment actually attain insulin independence. So we kind of took that figure from that research. And in the low immune response, we say that there's a possibility of having a low immune response where you would have no anti-rejection medication needed, and your islet cells would be preserved in that packet, or you would have a high immune response in which you would have to take anti-rejection medication in order to keep most of the islet cells preserved. Now notice we also assume that islet cells have to be preserved, because if they were not, there would be no clinical or therapeutic benefit and thus no cost savings. So those are some of the assumptions we have to make from this specific trial. And based on those combinations, we came up with these 4 scenarios. You'll notice in scenarios 1 and 2, they both have partial proportions of the population attaining insulin independence. How that implicates the cost savings, that only allows for 44% of the total potential cost savings. Why is that? Because only 44% of the population are actually attaining insulin independence. They're differentiated by the immune response. So you'll see in scenarios 1 and 3, the high response scenarios, we say that impacts the cost savings in 2 ways. One, it reduces potential cost savings by the cost of anti-rejection medication. And 2, it reduces potential cost savings by 25%, because these medications have side effects. They're not gonna, they're not completely safe to take. And so we say that the cost savings are reduced by 25%. And then if you back out the numbers, which I'll explain in the next slide, we came out to the potential cost savings with these percentages. So in this next slide, what you'll see in the bottom there is the baseline cost. We attain this number through pertinent literature, and these are the incremental costs for each of these cost sections: inpatient, outpatient, medication, secondary complications, and work productivity. These are all costs attributed to having diabetes, so they're the incremental costs. So you'll see in scenario 1, it's about 30% of the baseline cost, and in scenario 4, it's about it's essentially a full cure. I simplified the chart here to only show scenario 1 and 4 because that was how we're showing the highest and the lowest efficacy. And so how we attain this total cost savings number is basically by taking the direct medical savings, which is highlighted in the green, and adding it to the work productivity, which is right next to it. And we multiply based on the actual scenario, and that's this potential cost savings factor, and that's basically whether or not you're insulin independent, it's full or partial, or if you have an immune response low or high, and that contributes to the difference in the percent of the baseline cost. And you'll see in scenario 1, you also subtract the additional medication cost. So the insights, again, scenario 1 scenario 4 assumes a full cure equivalent. And also the secondary complications, you'll see in that column, it actually makes up 40% of the direct medical savings. So this is what's going to cause a huge portion of the potential cost savings in type 1 diabetes. And lastly, you'll see that full insulin independence affects the cost savings the most, mostly because we're having a 44%, only 44% of the population actually attaining the benefit. And then if you aggregate based on that patient population, you'll see that the estimated annual cost savings is about $962 million to $3.2 billion per annum. And now that concludes my section on type 1 diabetes, and we'll move on to the next disease. Thank you.
Okay, so we now move to breast cancer. And breast cancer is defined by cancer forming in the breast area and is the most common cancer occurring in women in the United States. In 2014, the prevalence for breast cancer was estimated to be about 364,000 people in California, and this number includes people who have or had breast cancer. The image on the right shows the stages of breast cancer, and if you can see, the progression of the disease means that the tumor will grow larger, and also your survival rate decreases. And by stage 4, it could have moved to other organs, which decreases your survival rate significantly. And the current treatment mechanisms include BCS, which is breast-conserving surgery, mastectomy, radiation, hormone therapy, chemotherapy, HER2, and I would like to stress that this is not a complete list. The treatment types would vary a lot by the genetics and the condition of the patient, and also on the progression of the cancer. And it is estimated to cost anywhere between $20,000 to $200,000. On the next point, for information about the therapy mechanism, we interviewed Dr. Irv Weisman. And he explained to us that in our cells, we have, on the surface of our cells, we have a CD47 protein, which emits the signal, "Don't eat me." And this "don't eat me" signal prevents the macrophages from eating the cells up until about 100 days, which is the life expectancy of a normal cell. However, cancer cells kind of use this signal to not die and then reproduce more cancerous stem cells. And what the research team aims to do is develop an anti-CD47 therapy, which would allow for effective attack on and elimination of cancerous stem cells. So to explain how we did the scenarios for the cost saving, we came up with 3, and each with different percentages of cost savings attained. So if you look at scenario 1, it is the least effective, and there is only 25% of cost savings attained. This means that the drug is not too effective and cannot replace current standard therapy very significantly. We thus expect the lowest cost savings for scenario 1. And for scenario 2, it is moderate at 50%, and at scenario 3, it is at 75%, which means that the drug is significantly effective. So scenario 1 is the least effective and has the least percentages of cost savings, and scenario 3 is the most at 75%. As for methodology on the right, we calculated these direct cost savings by using prevalence data from pertinent literature. But we do want to note that for indirect cost savings, because of the lack of data information that we had, we did not include in the cost savings scenario analysis. However, we would like to note that the loss for productivity or indirect costs are pretty significant. And in the last slide, we give you a table of how we were able to compute the total cost savings from the per capita cost savings. And before elaborating, we do want to point out for breast cancer that the new therapy cannot completely replace physical surgery or some chemotherapy. And physical surgery refers to mastectomy or breast conserving surgery or BCS. So if you look at the average cost savings, it's pretty low compared to how much you would imagine it costs for a typical breast cancer patient would expect to pay. So it's pretty low. And then before, I would like you to take note of the columns, which says initial early, initial advanced, last, and continuing. So this was taken from pertinent literature and relied on data that sorted prevalence by where the patients stood relative to the time since initial diagnosis. This means that at initial stage, because it's on their first year of diagnosis, these patients could be anywhere from stage 0, which has a very high survival rate, and it could also range to stage 3, which has like 44% survival rates. So that's why we had to separate it by early and advanced. And early, we grouped it to be stage 0, 1, and 2, and advanced for 3 and 4 for the purposes of our analysis. And last refers to people in their last year of lives, and we sorted that out by the date of people whose main cause of death was due to breast cancer. And then continuing refers to anywhere in between. And on the right, we give you an illustrating methodology of how the total cost savings were calculated from the per capita cost savings. And before elaborating, I do want you to take a note at the target cohort on the first arrow. And what the target cohort means is that when we interviewed Dr. Wiseman, he said that about 1/3 of the entire breast cancer patient population would not be able to benefit from the new stem cell therapy. And he said that it would be because of the genetics of the patient. So this means, this translates into saying that 1/3 of the population would have zero cost savings because they can only rely on the current treatment to cure breast cancer. But however, the 2/3 who do have the target cohort would produce cost savings. So let's say that if we wanted to find the total cost savings for scenario 1, initial early patients, what we would do is we would use the number of initial patients, which is 25,889, and then multiply by 87.45%, which is initial early patients. And we would multiply that by 1/3 without the target cohort, which is 0, plus 2 times of the population with the target cohort, which we found the cost savings in the per capita as 2161. So if you add those up, you would get $44 million for scenario 1, initial early, and you find it for each column and each row. And this is how we got the total cost savings for each scenarios. And then you would want to compare that to the baseline cost, which is 1822 million, which is 1.822 billion. So this is how we calculate it, and you can compare by the scenarios how much the cost savings were attained. So this ends my slide about breast cancer, and I would like to give it to Christina, who's going to talk about HIV and AIDS.
Okay, thank you, Jen. Well, first, HIV AIDS. What is HIV AIDS? Well, HIV is a virus that infects the immune system. Specifically, it attacks a CD4 immune cell. What it does is that it will bind to the CD4 cell through a receptor called CCR5, and then infect the cell and replicate, killing the cell, and then replicate in the body. Eventually, the immune cells die off, and then HIV/AIDS patients often die because they have a weakened immune system. And so, in terms of California, we have a prevalence of about 0.32%. If you are an HIV/AIDS patient, the cost that you expect to incur would include things for antiretroviral therapy, opportunistic infections because you have a weakened immune system, outpatient costs, inpatient costs, etc. The average comes out to be about $13,000 per year per patient. Of interesting note is that only 40% of HIV/AIDS patients in California actually seek primary care, so that will be factored into our analysis later on. As for the therapy that we are now investigating, it is by CalImmune. It is in phase 1 and 2A, and what it does is first, it takes a little bit of blood from the HIV/AIDS patient. It removes the CCR5 co-receptor from the CD4 immune cells, knocks it down, and then returns that blood back into the patient, step 2. That leads to step 3. You have bone marrow stem cells and CD4 differentiated cells that potentially have a knocked down CCR5, which means they are now resistant to HIV. That is the theory that they are developing. And so what are the benefits of this therapy? Well, first, you have sustained HIV immunity. If you have current treatment right now, if you're indicated for taking antiretrovirals, you'll have to take antiretrovirals every day. However, if this therapy does eventually work, you could just have a one-off treatment and you would be HIV immune. You would functionally be cured. The second is that, like I said, there's infrequent administration, so it would be very easy for the patient to live. And so moving on to our cost scenarios. How did we come up with the varying cost scenarios with the different levels of savings? Well, first at the bottom you can see baseline costs. These are the average costs that a patient would have to pay per year per cost category. So for antiretrovirals, the patient would be expected to pay around $8,000 per year. And so let's come up with the first scenario, which is the least effective therapeutic scenario, scenario 1. What I did was that I anticipated cost reductions in each of these cost categories and then found a total per capita savings. So let's go through the numbers. First, for scenario 1, we can imagine a scenario in which the therapy is not entirely effective in creating those HIV immune cells. And so the patient would still have to take antiretroviral therapy concurrently with the therapy. And so you can see a 0 in the antiretroviral therapy savings because you still have to take the same antiretroviral therapy. For prophylaxis savings, we can see a positive number because supposedly if you have a few HIV immune cells, then you have a relatively more stable CD4 count, and hence you probably would have fewer opportunistic infections. And so you expect to see some savings in this category. The same reasoning goes for inpatient. If you have fewer opportunistic infections, perhaps you'll be less hospitalized, and so you would have savings there. And so if we sum that up, we have the 2,000 number that we see on the most right. And now let's look at scenario, and that's about 16% of the baseline, or 16% in savings. And so let's look at the most effective scenario now. This is the most effective therapeutic scenario. Again, we take those same cost categories, but now we have greater savings in each cost category. And we sum it up. You can see a 12,000 number on the right. And this is about 93% in savings. And so we do the same amount of cost reduction for intermediate scenarios as well, and you can see the numbers there. And so this is the calculation that I did for the direct cost savings for HIV and AIDS. And so let's take those same cost categories. We just calculated the per capita savings in each scenario. And now how did we come up with the aggregate savings? Well, for year 2014, we take the number of living cases of HIV/AIDS patients in the state, and then remember that I mentioned a 40% care participation rate. We factor that in right now to get the number of patients that are actually seeking care and hence actually incurring these costs. And we multiplied this number by the per capita savings to get the aggregate savings. And you can see the results. From the worst to the best scenario, we have anywhere from around $100 million in savings to almost $600 million in savings in 2014, assuming the therapy comes into market right now. And now we do the same calculations, but for work productivity. So in work productivity, we again have the same 4 scenarios with the same percentage cost savings, but let's first look at how we would approach the productivity losses calculations. With HIV/AIDS literature, there was very little on absenteeism and presenteeism as a source of work productivity loss. And so I only looked at lost income due to early mortality. And so how I calculated that approximated that there was approximately a 16-year average loss if you had HIV AIDS. And then you multiply that by the average wage for an average person in the United States. And after adjusting for net present value, you get this number that you see up there, which is the loss of income per death of HIV AIDS. Now, how many deaths are there in a given year? Well, let's do a separate calculation. There is around 120,000 living cases. You multiply that by the death rate, you get the approximately 2,000 deaths that you expect in a given year. Well, in this case, 2014. You move that up to multiply it by the loss per death to get the aggregate savings that you would get, well, the aggregate losses in work productivity. And so with that aggregate loss calculation, we now get the numbers on the right. If we tally all these up, we see that there's anywhere from 160 million to 930 million dollars in savings in the year 2015. So now, if we were to aggregate the direct cost savings and the reductions in work productivity losses, we see the following numbers. And a limitation of this sort of addition is that, as you may know, direct cost savings is a cash flow value, and then savings from reduction in work productivity is a net present value. So they are slightly different in terms of accounting, but just for a comparison reason, we tallied them up and added them up, and then at the bottom we can see the savings that we can expect should the therapy come into market in this year. And so now we go into overall analysis.
So just before we jump into the pricing analysis, we wanted to review and compare our findings for the specific diseases. And you'll notice that for type 1 diabetes, that has the highest direct medical cost per capita. That's largely due to the secondary complications that Jeremy already mentioned. You'll notice that breast cancer does have the highest prevalence, but as Jin mentioned, as we move forward into the analysis, 1/3 of that population is unable to receive the treatment. And finally, you'll notice that HIV AIDS has the highest work productivity losses, which will also really factor into the 10-year analysis that we next perform. In terms of pricing, we projected pricing based on market demand. We felt that other techniques of basing it off of degree of competition or production costs were not as useful, just because these drugs are so revolutionary. And in reviewing the literature, we found that market demand was primarily based on the cost savings that you could achieve. And we also found that very revolutionary drugs, like stem cell therapies, are able to capture 100% of medical cost savings. So we began with that assumption that the undiscounted price would capture 100% of those medical cost savings. However, Proposition 71 does have a specific clause that enumerates that any payments from public funds will receive a discounted price, and that there will also be a discounted price for those who are unable to purchase the drug due to financial constraints. So in order to factor that in, we calculated a weighted average discount overall, and you'll see an illustrative calculation on the right-hand side. So we broke down categories into the different payers who would be paying for this drug. In this first example, it's private insurance. And we found that private insurers account for 35% of overall healthcare spending, and we assumed that due to their market power, they could secure a 15% discount, which gives us a weighted discount of 5.3%. We performed the same analysis for Medicaid and a host of other payers, which is detailed in the appendix, and that gave us a weighted average discount of 28.7% for a price that is at 71.3% of total direct medical cost savings. We do acknowledge that this weighted average discount might be slightly underweighted. It excludes analysis of people who are currently not seeking medical treatment, but due to financial constraints, but might come out when there's a new discount, and we weren't able to quantify who is in that category. So we perform a sensitivity analysis where there's a 50% discount, and that's also in our appendix. After backing out the pricing, we were able to look at the net cost savings in each scenario, and in scenario 1, or the moderate efficacy scenario, we found that overall, Californians and the state government were able to achieve $6.3 billion over 10 years, and that's discounted. And you'll notice that type 1 diabetes accounts for over half, or 56%, of these total cost savings. That's largely due to the growing prevalence rate, which is a much higher rate compared to the other two diseases. You'll notice that breast cancer has a slightly lower range of cost savings, and that's again due to the fact that a large portion of the population cannot receive the treatment. And you'll also notice that HIV AIDS also has low cost savings, but that low net cost savings, but that most of it is attributed to work productivity, and that's due to the analysis that Christina performed, showing us that work productivity constitutes a large amount of HIV/AIDS cost savings. If we go to the high efficacy scenario, we see that Californians, as well as the state, saved $22.8 billion discounted over the next 10 years. You'll notice that type 1 diabetes still contributes, that HIV/AIDS work productivity absolutely jumps because we're going to a full cure. On the right-hand side, we've done a breakdown of total cost savings, so you can see the sources of net healthcare costs as well as the source from increased productivity. And we also calculate an expected value of net cost savings. So far, we've only assumed that 100% of the drugs will come to market. However, in reviewing the literature, we found that out of drugs from phase 1 clinical trials, only 15.3% receive FDA approval and make it to the market. And so using that percentage, we calculate the expected value incorporating that.
What discount rate did you use?
Huh?
What's your discount rate?
The discount rate was 3.2%, the rate on a treasury bond for 10 years. So now we go into the savings to the state of California, and you'll notice that on the left-hand side in the moderate efficacy scenario, Medicaid, which is that bright red, saves $233 million over 10 years. And on the right side, in the high efficacy scenario, Medicaid saves $851 million over 10 years. And that of these sources of California state spending on healthcare, they're roughly distributed between Medicaid, the private insurance premium, and other healthcare programs, which includes things like CHIP and child and maternal health. So overall, our findings show that the state of California can save a substantial amount, $613 million to $2.2 billion. However, this is still less than the $6 billion cost of issuing Proposition 71 bonds. If you couch it in terms of the residents and the state of California, you see that they can save $6.3 billion to $22.8 billion overall. And if you look at the expected value, the savings go to $962 million to $3.5 billion. There are some limitations of our analysis. First of all, we exclude the later years of the bond payback period. So the bond payback period does extend beyond the 10-year period that we look at. And we also exclude other benefits like caregiver work productivity, as well as quality of life benefits such as reduced side effects, which we discussed earlier. We made several recommendations to CIRM and to Americans for Cures in terms of improving our analysis. The first one was estimating the therapy-specific probabilities of approval. Instead of just using that 15.3%, we might be able to parse out which ones are more likely to make it to the market than others. The second thing we would like to do is understand the scenarios in more detail. Right now, the therapies are in such early phases, it's really hard to decide exactly which scenario is most likely. And finally, we recommended that they analyze other therapies, which might potentially have lower cost savings just due to the nature of how we selected our diseases. So that concludes our presentation. I think we would really like to thank the Public Policy Program for making this project possible. We certainly learned a lot, and especially our advisor Larry, who was with us and taught us a ton about quantitative analysis, made himself available sometimes until 3 a.m. on multiple occasions to help us through the model.
Stop setting that example.
He was very helpful and really taught us a lot. So thank you so much. We're now open to questions.
Question. Let me see if I understand. The way you set up the structure of the methodology, if I understand correctly, it will always give you a positive net cost saving. And let's see if I understand. You never have a scenario that gives you zero or negative cost savings, and you always calculate a price as a percentage of the positive cost saving. So by the way you structure this, it will always be good. Is that right?
So it could potentially become negative if you said that the price was like more than 100% of the direct medical cost savings, which could be a scenario that occurs. So like one of the PIs that we talked to said that it would not only capture direct medical cost savings, but could also capture quality of life benefits. So if you decided that that was in fact true and that it would be above 100%, then it would give you a negative number in the cost saving scenario.
True, but with the methodology you're using, there's no way. With the assumptions you're using, there's no way it's going to be negative, right?
Success.
Yeah, I guess so, because we are assuming 100% success.
Of some sort. Yeah.
And you're also assuming the 71.3% of the price.
Yes, yeah.
Okay.
That was going to be my question. I actually wanted to, sorry, I didn't want to jump in front of somebody else. So just using the HIV example, Christina, is there a scenario in which the drug doesn't work at all?
So, in terms of the scope of this project, we're assuming that the therapy does work, and so we're taking various levels of working.
And how do we know, and why do we make that assumption that it will work at some level?
I think mostly to attain a feasible project in the 10 weeks that we're given. We could obviously take into account the probability of a successful therapy at all. That would be additional analyses and additional.
But these drugs are at what stage of development?
Various, yeah.
Sorry, very early stage.
Yeah, so one of the PIs we talked to said that his therapy might not work or could cure cancer. So the confidence interval is very wide, which is why we don't attempt the probabilistic analysis. I just have one thought back to your question. So I guess our analysis does always spit out a positive number based on that discount, but that's just based on the potential benefits of these therapies, and it's not a cost-benefit analysis of Proposition 71 on the whole. So if you were to do that cost-benefit analysis, then you might get some negative numbers in terms of the actual cost of these therapies.
And that plays into David's point, which is that's a cost that if it doesn't work, the cost is there.
Yeah.
Yeah, and that's definitely something we would like to do, or that would improve our analysis, but just for the 10 weeks to make it feasible, we decided to just focus on the benefits.
Also, the science is difficult to really project. By site, the type 1 diabetes trial, they just implanted a device in the first patient on like the end of October, so it's only been a month, and so it's really hard. When we interviewed the PI, any question we asked about scenarios, he said, you know, I played the fifth, I can't say anything.
So they created a box for you. The client created this box, so this sort of this world for you, and in that world, you only had the following choices, and none of those choices were the drug doesn't work.
Well, they built a model that has assumptions. If you can vary the assumptions, you get different results.
But Bruce, they're not allowed to vary an assumption to the point of saying the drug doesn't work.
Well, it didn't work for 2/3 of the people in one case. They could change that number to be 100%.
Well, but even in that case, like scenario one of the AIDS, you mentioned that for 1/3 of the population in the less effective scenario it wouldn't work, right? But then you said that is a net cost, or sorry, a cost saving of 0 for that third of the population. But that's not actually right, because if you don't know who that third of the population is, you have to apply the treatment to everyone, and for a third it will not work. Or you have to do a genetic test, and that would be a cost, so you know whom to apply. So there's a cost to that third of the population.
I think the
It could
1/3
turn negative.
is actually for breast cancer,
Yeah.
and I think that
Oh,
should be
sorry,
factored
breast
into
cancer.
that, yeah.
Yeah, and they do the testing. I mean, that's part of the state of the.
So there's a
Part
cost. It's not a 0.
No, but it's done now.
It's already done.
It's already done.
They know.
Yeah, because genetics are very important now in deciding how you treat a particular cancer.
So there's not
They're
an additional
elaborately
cost.
differentiated. So,
I have a couple of questions that have got no relationship to the project. I'm just curious, how many breast cancer patients are male?
So there are some, but the percentages were too low, and for the purposes of our analysis, we decided to take them out. I can't give you an exact number or percentage for now, but it does exist, and it's
Would the therapies work in each case though?
for the male
I mean,
population.
you know, the predominance of breast cancer victims are women.
Yes.
We all know that. And that predisposes you to think, well, perhaps it's related to hormones in some senses because the different hormonal composition. I mean, could be. That then suggests that therapies that might work on women wouldn't work on men. So it would change the results quite a bit if there was a significant proportion of males.
Right, definitely.
Just a
We just
curiosity.
made an assumption that it would.
Yeah. The other question, you said only 40% of AIDS sufferers actually go into care. Now, I presume that many of those that don't go into care, I mean, they may be taking antiretrovirals or something of this kind, but do they then subsequently get extraordinarily sick and become a very heavy cost on the Medicare, Medicaid system?
So I think, and correct me if I'm wrong, Christina, but that 40% was people who So your point is that even because they're not seeking treatment for HIV/AIDS,
Now.
now they have to, they're
They'll
a
show
burden
up at
later
some
on
point,
for
yeah,
something
yeah,
else.
you know, that doesn't mean you just give everybody the treatment, but it does suggest that there may be some really heavy costs associated with end-of-life situations for people who never sought treatment.
Yeah.
And if you could somehow induce these people to come forward, there could be actually quite substantial additional savings that could be available from these therapies.
Sure, yeah, I think, so end-of-life costs was also something that we excluded from our analysis just because it was hard to attribute it to the disease, but that's definitely another huge potential source of cost savings. That's a great point.
Sorry, just to answer that, we also have bottom-up numbers that show California public spending on HIV/AIDS, and I can imagine that that captures the ER costs and any other costs for people who don't normally seek care. So in the paper, we've addressed that.
Yeah, okay.
First, I think you did an excellent presentation. I know it was a lot of work to do what you did. I think both teams did a really great job, and I know Larry did a wonderful job mentoring them. And I know you presented on Tuesday to your client, and I was wondering what the client feedback was and how maybe the client will be using this analysis. The work that you did here.
Sure. No, do you want to answer that, Jeremy?
So I actually worked with Americans for Cures this past summer, and you know, it's hard to say. Right now they're kind of like in the financing stage where they're trying to get like donors, and you know, this is the kind of numbers that they need to show like the donors, like, okay, this is what potentially we could save. You know, there's no, like, because the therapies aren't out there right now, we're not curing anybody, because when people first voted on this in 2004, they thought, okay, we're voting for cures. No, we're voting on the basic science for the cures. People didn't understand that. And so I think with this, this provides the client with some numerical values of again, it's the potential cost savings. They're not saying this is going to happen. They're not saying that this is what has happened. It's that if the cure were to happen today, this is what the potential cost savings would come out to be. And you know what Bob Klein, our client, how he responded to some of these numbers. You know, he's very positive with them. He questioned some of the prevalence numbers. He questioned some of the you know, the data. He was fine with the methodology, but in terms of like the actual prevalence numbers, he thought they could be higher. Or he thought they could be, you know, because his wife had breast cancer and his son has type 1 diabetes, so he thinks he has this kind of like other mindset of like what the numbers could be.
He thinks they should all be higher. He never said, oh, he
said they could be higher.
He didn't have problems.
He was less of a skeptic.
Exactly. Having the opposite
Skeptics
responses.
The problems of economists, he generalizes on the basis of a single observation.
There's a cognitive bias there.
Yeah.
But it's interesting how both teams have the same client, and for you, kind of, you're giving the positive aspects of all of these, but for you guys, the client gave you the restriction that firms would find it too uncertain to invest in these things that are so great, right? So it's kind of weird that you're...
I think that was largely based on the, oh, go ahead.
Oh, sorry. And I think he also wanted us to focus kind of on the quality of life and how cost savings could improve the quality of life, which isn't quantified in our analysis, but he said if it could be quantified, it could be massive.
Yeah, I think they wanted us to include more in our potential cost savings at the midpoint check, and I think we had 20 different things that he wanted us to add in, but we just couldn't given the time constraints.
Great, thank you both.
Great job.
I have a quick question, which maybe you guys don't know because it's totally outside the scope of the project, but would the cost savings of diseases vary on a national level versus a state level? Like, is there a predominant disease within California that doesn't really occur on the national level?
Right, so I won't speak for the other two diseases, but in terms of my numbers for type 1 diabetes, I actually couldn't obtain California-specific numbers. I just took the California proportion of the population in the U.S. and just multiplied it across.
Same for breast cancer.
I feel like HIV/AIDS high concentration in the major cities of California. I don't know for sure, but I would like to say yes, there's a slightly higher prevalence for California.
And just to make a couple of comments, and yeah, clearly in this project, it's a piece of a bigger analysis. And so prior to the students doing this work, there was no assessment at all of conditional upon the therapies being approved. what potential cost impacts there might be. So, so they were, their job was to fill in, that part of the puzzle. And, it's not complete. And they did, to give them, a little bit of due, they did, look at the probability of the drugs getting approved and made an expected value calculation on that. And, and indicated, in terms of one of the priorities for looking ahead, research looking ahead would be to more seriously assess the probabilities. And maybe for these types of treatments, it's only 5%, since they're very cutting edge. To get to your question about, well, if the savings are potentially so great, why aren't the, and whatever that number is, there's a lot of uncertainty about it. The standard deviation of the expectation is very wide because this is a new area of science. So, and there's a variety of things they could do that would have produced higher or lower numbers. And in their report, they lay out a number of limitations and even a more detailed list of things that future analysis could do. So, but yes, both teams found that the way that your client, whether it's an outside client or your boss or the legislator that you work for, the way they frame the analysis is extremely important in terms of what you can really look at or not. And there you have it.
I think what impresses me that you've learned that if you make your assumptions clear, it doesn't really matter how improbable they are.
It will be quoted out of context.
But, in a sense, you make the assumption. Somebody's got to make heroic assumptions to actually generate numbers that you can look at. And if you don't make those assumptions, you never get a framework to go ahead and do the analysis. If they don't like the assumptions, if they know what they are, they can change them. If they don't know what they are, and they don't like what you've come up with, then it's useless. They throw it away and say, oh, that's totally implausible. But you've actually given a framework, they can think about it, and they can say, well, this should have probably been a bit higher, this is a bit lower, this situation couldn't possibly arise. I'm very impressed.
I want to thank both groups, and Mary and Larry, for this was fantastic. You all answered questions incredibly well. You knew your material down to the details of the science on everything, and the details of budgeting and everything. It was great. It was really, really well done.
Very well. Is that an A?